Hi, I'm Dr. Deva Boone of the Southwest Parathyroid Center. Let's talk about parathyroid hyperplasia. Parathyroid hyperplasia is referring to all four parathyroid glands becoming enlarged. But what am I really talking about? Let's first look at primary hyperparathyroidism. With primary hyperparathyroidism, typically you're going to have a high calcium level and a high or normal parathyroid hormone or PTH level. And what is happening there is that one or more of your parathyroid glands is overactive. Most commonly, this is due to a parathyroid adenoma. That's a benign parathyroid tumor that grows within one or more of the parathyroid glands. So the most common scenario when I operate is to find one, possibly two of these benign parathyroid adenomas. But sometimes, in about 10% of cases, when I go in there, instead of finding that one adenoma and 3 normal glands, I find that all 4 parathyroid glands are diseased. And that is called parathyroid hyperplasia. Hyper just means overactive. Hyperplasia is referring to the fact that the cells are growing and you get enlargement of all 4 parathyroid glands. Okay, so what does it mean? How does this differ from the adenomas? Well, in a lot of ways, it doesn't. Parathyroid hyperplasia and a parathyroid adenoma can produce exactly the same symptoms, exactly the same labs. Everything will look exactly the same. The only difference is that in the operating room, instead of finding one parathyroid adenoma, I find 4 abnormal glands. They're not adenomas exactly because they're not those benign tumors, but it's a benign growth of the parathyroid glands. So it presents the same way, labs look the same, and for the most part, your outcomes are the same as well. So most people are cured with surgery, they will have normal calcium levels after surgery, they'll feel better, the symptoms will get better, everything else is the same. Now, the natural question is, what do you do once you're in there? You don't want to remove all 4 parathyroid glands because you do need some parathyroid tissue in order to make parathyroid hormone and keep your calcium level in a normal range. If you don't have enough parathyroid hormone, that's called hypoparathyroidism, and that is its own set of problems. We really don't want to cause that. We want to keep it so you have some PTH, some parathyroid function, so you can regulate your calcium. But you really only need one parathyroid gland or part of a parathyroid gland to do that. So with hyperplasia, what I do is I go in there, I look at all 4 glands, and before I take anything out or remove any glands, I try to find the best looking one, the one that is looking the most normal out of all 4. And it has to be in a location where I could potentially get to it again if I have to. So let's suppose that the most normal looking gland, the best looking gland, is the right lower gland here. So I'm going to check out that gland. I want to leave in part of it, take a little tiny biopsy, but I want to leave in a part that is about the size of a normal gland. Sometimes that means taking out half of it. Sometimes that means taking out 3/4 of it. Sometimes it means just leaving in most of it if it's already pretty normal in size. But I want to leave in kind of a normal size gland in there. And once I've confirmed to myself that it looks good, I can remove the other 3 parathyroid glands. I am leaving behind parathyroid that's not normal, right? It's not like it's a perfectly normal gland. I know that it's not. I know it's also got hyperplasia just like the others. And so there is always a risk that it could become a problem in the future. In that case, what I do is I want to make it easy for myself if I ever have to go back in and see it, even if it's 10 years down the road. So I always put a bright blue stitch next to that gland so that I can find it again. So it's a proline stitch, it doesn't dissolve. That way, if you do have problems with it 10 years down the road, I can go in there and I have a little signpost sitting next to it so we can find that gland again more easily. And at that point, usually it means removing a little bit more of it. But for most people, they don't ever need that done. They are cured with one operation and they're left with a little piece of parathyroid that is the most normal appearing one, so it tends to work pretty well and regulate the calcium and not cause problems down the road. But if it does, then we have that marker there so we can find it again. Okay, now shifting gears a little bit, just want to mention that with secondary hyperparathyroidism, everyone gets hyperplasia. So this is very different. So with primary hyperparathyroidism, most people are going to have these benign adenomas, benign tumors, and they're going to happen in one or possibly two glands. But about 10% of people will get hyperplasia, all four glands enlarged. Now, secondary hyperparathyroidism is different because everyone gets hyperplasia. That's just part of it. Part of the disease is that you get hyperplasia. Remember that with secondary hyperparathyroidism, the underlying issue is not with the parathyroids. The parathyroids are actually doing their job. They just have to work really, really hard to do it. So they're trying to keep your calcium up and they're having to make a lot of hormone in order to do so. And that's happening to all four glands. All four glands are just cranking out parathyroid hormone as much as they can. And when they do that, they start to get larger. That's hyperplasia. Secondary hyperparathyroidism, everyone gets hyperplasia if you need to have surgery for it. If you have mild secondary hyperparathyroidism, actually you probably don't have hyperplasia. If your PTH is just a little bit elevated, a lot of times once you can get your calcium level up, the PTH level can drop. But if you let your secondary hyperparathyroidism go, you will see that enlargement. It'll happen over a long period of time, but you will see hyperplasia. So just to recap, hyperplasia is what we find in the operating room when all four parathyroid glands are enlarged. It occurs in some patients with primary hyperparathyroidism, and for those with long-standing secondary hyperparathyroidism, that's what we're definitely going to see in every patient. But it still happens in about 10% of patients with primary hyperparathyroidism. It presents the same. It's the same disease. It's still primary hyperparathyroidism. You have the same symptoms and the same outcomes from surgery. You just have a little bit different of a process in the OR. Instead of removing one gland, I'm removing 3.5. And that's really the big difference between the two. Okay, take care.